You're listening to Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and a clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
I'm Dr. Carol Wysham. Welcome to Season 3 of Medscape Type 2 Diabetes podcast series. Today, we'll be discussing managing diabetes in the elderly population, understanding geriatric syndromes and how they impact care, and how and when to de-escalate medical treatment. First, let me introduce my guest, Dr. Medha Munshi. Dr. Munshi is a professor of medicine at the Harvard Medical School. She is a geriatrician and an endocrinologist. She practices primary care geriatrics at the Beth Israel Deaconess Medical Center and directs the Geriatric Diabetes Program at the Joslin Diabetes Center. Dr. Munshi, welcome to the Medscape In Discussion Type 2 Diabetes podcast.
Well, thank you, Dr. Wysham. It's always a pleasure to come and talk to you.
I feel the same way. Thank you. So, first of all, I know that you've been focused on research and education on the topic of management of diabetes in the elderly for probably 2 decades. Please share with us, how did you first become interested in this area?
So first I did my endocrine fellowship, so I knew about diabetes well. And then with variety of reasons, as life happens, I ended up doing a geriatric fellowship. And as I started working on this area, I absolutely loved it. And as I was working in geriatrics, people started sort of sending their patients with diabetes to me because they knew I was a diabetologist. And I started realizing that there was a difference in how the patients presented, what their background was, and how I was managing the diabetes. So I started studying them, and then my clinic became my laboratory. Then I moved from Little Rock, Arkansas to Boston. Joslin Diabetes Clinic did not have program. Actually, geriatric diabetes was not really a thing at the time. And I was given opportunity to start the program. So that's how I ended up there.
Oh, thank you. As you know, I share your interest, and in similar vein, just having experience in diabetes and having patients age through, it is clearly different to manage this population. So give us a perspective. How many people in the U.S. and the world with diabetes are over the age of 65?
In general, if you look at the diabetes in general, about 830 million people in the world, and 38 million of them in US have diabetes. But aging is different in different parts of the world. And with the baby boomers aging in United States, we have now increasing number of older adults. The popular number was 10,000 people turning 65 every day for about 2 to 3 years. And the prevalence of diabetes is higher in aging individuals. So we have about 29% of the population over age of 65 who have diagnosis of diabetes. So that makes about over 11 million people, and that's increasing. So we are seeing a real shift in time. The idea is that any specialty of medicine you are practicing in, you are going to see more and more older adults and those with diabetes.
So there are what's called geriatric syndromes, as you well know, and it'd be interesting just to have a quick overview of what those are and how they impact the care of the older person with diabetes.
Geriatric syndrome is basically some of the conditions that do seem to occur with aging and with higher prevalence with diabetes. And it includes conditions such as cognitive dysfunction, depression, functional or physical impairment or dependency, polypharmacy, which is taking multiple medications daily, chronic pain, incontinence, and so forth. And the importance of identifying these conditions is because as diabetologists, we intuitively don't think about them. They are not part of our macrovascular, microvascular complication cohort. So these conditions are quite subtle. Many a times, patients themselves or their caregivers and us as clinicians don't recognize them. However, they do impact patients' ability to do self care and manage their therapy, especially if it is complex therapy. So, there lies the importance of recognizing what geriatric syndromes are and whether the patient has them or not.
I'd like to just clarify a little bit. So, really, we're identifying two different risks, at least in my view. One is understanding how the geriatric syndromes might impact the quality and the duration of life expectancy. And the other is the ability for people to be able to carry out their self care. So, maybe a little bit of clarification on how we identify those patients who really are older, maybe than even their chronological age, and how the other aspect, the effects of chronic care or chronic disease.
And you are absolutely right. The same conditions that we describe in geriatric syndrome could be also comorbidities, right? That's what you are mentioning. And comorbidities could be that as well as other like cardiovascular conditions or stroke or many other comorbid conditions that are actually what we in geriatrics think of it as competing comorbidities. That when somebody has these conditions or even cancer and so forth, how important is diabetes management for them, considering the impact of these comorbidities on life expectancy and so forth. So that is absolutely a part of consideration. The geriatric syndrome is more sort of a coexisting conditions that impact the self-care and the patient's ability to perform their day-to-day diabetes care. And fine differences, but it's essentially one big overall picture of what else is going on with that patient. Yes.
So, can you review with us the risks of overly aggressive diabetes management in the older adult?
Yeah, so as we know that in older adults, typically one of the major difference between older and younger adults with diabetes is having comorbidities. And some of the common comorbidities or conditions such as high cholesterol or high blood pressure, we know that everybody is managing. Diabetes is a little bit different, that the goal for glycemia has upper level and lower level. So there is a target that has both too high or too low levels that are not necessarily worrisome in other chronic condition. And so when we think about what should be the goal for any individual, we want to think about benefits of lowering the high glucose and risk of going too low. Now, benefits of lowering high blood glucose is typically avoiding long-term complications, versus low glucose causes poor outcomes such as falls, fractures, or decline in cognition or even cardiac events. And as we get older, that benefit and risk assessment needs to be done more carefully, because as we get older into the 80s and 90s, the risk of today someone having low blood sugar and having fall and fracture and ending up in a nursing home are much more worrisome than a concern about long-term complications that they may not have time to develop. And the other side of that equation is how that over-treatment or the complexity of the regimen impacts patients' quality of life, because that's another concern that we have, that overly complex treatments may make patient stressed and having difficulty following those regimen, and that can impact their and their caregivers' quality of life.
Yeah, that's very important information. And thinking about the patient and addressing their concerns about good glycemic control versus their risks of being overly treated, how do you address that older patient that wants to keep their A1C less than 7%? I mean, that actually comes up in my practice literally every day.
All the time. I think part of it is to explain to the patient. I think when patients come and say, but I have, for years fought to keep my A1C under 7%. Why are you saying that? Are you giving up on me? Right? And the idea is that I start with asking them that let's talk about why are we doing that? Why do you think we are trying to keep your A1C under 7%? And typically starting to that point and talking about development of long-term complications, how long, in geriatrics, we are fond of talking about time to benefit, right? That how long does it take for a tight control to benefit, which is in diabetes somewhere around 5 to 7 years. So what are the then risks of keeping your A1C under 7%, especially if you are on medications that have high risk of hypoglycemia? And I think gradually showing them the logic behind why we are doing and the fact that it is not giving up on them, but rather making sure that the benefits of the treatment remains without risk of the treatment.
My comment on this is that it might take 20 years for your high blood sugar to have a major impact, but hypoglycemia can kill you today. That's what I try to explain to people. But, it doesn't always work. Some of them still insist, or they'll come in the next visit. Oh, they're sorry their A1C is 7.1 and want it to be under 7. Well, speaking of A1Cs, there was a recent article that was published that confirmed something that you actually showed about over 10 years ago anyway, and that is that A1C is a poor surrogate for risk of hypoglycemia. Do you want to review that concept with the audience? I appreciate that.
That is one of the primary ways you could convince a patient, because A1C is a mean glucose over last 3 months, right? So the mean glucose does not show excursions. You could have glucose at 440 every day, and your mean glucose might come up somewhere where is reasonable. It also does not show how many times or how long the person spends in low blood sugar when you check the mean glucose. So we are now fortunate to have excellent technology, which are now becoming a lot more common in practice and covered by many of the insurances, especially the continuous glucose monitoring. And it has shown us how, fallibility of A1C, especially on the other side, the hemoglobin A1C is, when we measure A1C, we are measuring glycation of RBC molecule. When the RBC molecule does not live for 3 months, that's what we presume, that it's a normal lifespan of RBC, or the turnover of RBC is not normal, then actually the value of A1C may not be appropriate or reflect the true glycemia either. And the conditions such as anemia, blood loss, acute infection, the conditions that actually make that A1C value not reliable do occur very commonly in our older population. So that's another reason why A1C may not be appropriate to make treatment changes, especially in patient. And, when patient has really concern about A1C value, and I'm really worried about them having hypoglycemia episode, having a professional CGM, which is just a 2 weeks worth of pattern, that is not necessarily requiring patient input, can show me and the patient that, look how much time you are spending in low glucose. And it's not just about falls and fractures, but the cognitive impairment, right? Brain only uses glucose to function. And most of the older adults are really worried about cognitive impairment. And that many times convinces them that let's just not go overboard, especially if there is no benefit of doing this tight control.
I think that's very important. I just want to emphasize that since we're talking about the older adult, and the vast majority of them will have Medicare, that the professional CGM is very well covered by Medicare without regard to background medications, and that all of our patients on basal insulin with Medicare are candidates for CGM if it fits into their particular situation. So just emphasizing that we can use this technology in the majority of our patients to help understand that. So, speaking of advanced technologies, how do you decide upon when it's appropriate for a patient to have, for instance, a personal CGM at their disposal?
I think that's probably a most contentious issue when I talk with my geriatrician colleagues versus my endocrinologist colleague. I think what I would say is that we understand that older adults are not homogeneous population, right? There are older adults who are very healthy, very capable, cognitively intact, functionally intact, versus older adults who are more frail and dependent. And if we decide on right technology for the right patient, then I think we can minimize the burden of the technology and maximize the benefit. So whenever I think about a technology, I ask myself three questions. Why am I doing that? Is this because the patient requires more information about how his or her lifestyle is impacting the glucose level? Are you doing fine with your diet? What does exercise do your glucose level? Or if your medications are doing right for your glucose level? If that is the purpose, and that is the purpose for many of these healthy, functional people, then personal CGM is very appropriate as long as we tell them why we are doing that. In many of my patients, it is the caregiver who are really asking that I don't know when mom has low blood sugar, what is the best way? And then the one with the share feature would be a good one. So then we are decreasing burden, increasing benefit. And then there is a large cohort where patients are not capable, they are frustrated and overwhelmed. I, as a clinician, want to know what's happening. Are they getting low overnight? Or how do I change the therapy because it seems like they are not doing well? Then professional CGM is the right thing to do. So if you think about it, three things why we are doing it. One is to decrease the risk of hypoglycemia. Second thing is to help them get better glycemic control. And the last thing is improve quality of life. And if we are doing it for the right reason to the right patient, I think we can do well without increasing burden.
I think that's all very important information. I also have that question, at least in my own practice, how and when do you take away technology? So, how do you make the decision when it's appropriate to suggest that technology should be removed?
I think you might be then thinking about more sort of a insulin pump or the automated insulin delivery. Usually, continuous glucose monitoring, it's not necessarily to take it away because the worst they can do is not use appropriately. And that we can continue to educate. The bigger problem comes when people who are on insulin pump or automated insulin delivery system who start getting multiple hypoglycemic episodes, and you can see that the caregivers are stressed about that. It is a very difficult decision because people who are used to that, and especially most of them have type 1 diabetes, and they really like that independence from monitoring and multi-dose insulin. I typically start telling them why I think that their technology is not working for them. Not only that, but it's hurting them, and then carry on that conversation. It takes me many a times 5, 6, 7, 8 visits before I can convince some of them. Unfortunately, many a times they end up in the hospital because of the failure of the technology. And then once they are in the hospital and then the pump or the AID is taken away, and then they realize that there is no way to put it back on and carry on. And that's where they start not using that. I do, though, hope that as the AID is improving and becoming more patient friendly and requiring less patient input, this frailest of all people with type 1 diabetes would be able to use them. We are not there yet, though.
I think we're pretty close with one of the AIDs in that they've shown pretty decent control, even if patients don't bolus. I just wish we could lock the pump so that the patients can't bolus. That's one of the big issues that I frequently have, even to the point that patients are getting confused about how they treat hypoglycemia and they actually think they need to bolus. Well, that leads us probably to our frailest of frail patients, and that is the patients in assisted living or skilled nursing. What advice do you have about managing diabetes in those settings?
I don't know if I have a whole lot of advice, as I really have concerns that we really need to do something about that. And the reason is that these facilities are highly regulated facilities and they require specific protocols that are embedded into their care protocols for different types of technologies to be used there. There is no reason why continuous glucose monitoring cannot be used in these technologies efficiently. But what that is going to require is more studies that approve their use. And then we have to actually educate the staff of the long term care facility or skilled nursing facility or rehab facility on how to use them. The biggest problem with these facilities is that the staff keeps on changing. So we need sort of an educational program that are embedded in their in services and so forth that can do that. This is not a rocket science. We can do that. We just need resources and we need some help in developing that. But as we talked about it, more people are getting older, and this all older cohort is going to require some rehab at some point, some assisted care facilities at some point, and time to prepare for that is now.
I think that's really important. And I share with you the frustration that we haven't been able to move forward with the use of these technologies in these settings. Well, I want to thank you so much for sharing your advice with us. It was very interesting and very helpful. Today, we've talked to Dr. Munshi about the management of patients in older adults and how comorbidities can impact their care, how we can use technologies to help improve the outcomes of our patients with diabetes. I want to thank the audience for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on type 2 diabetes. This is Dr. Carol Wysham for the Medscape in Discussion Type 2 Diabetes podcast.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.